I'm very pleased to be able to share with you Gavi's commitment to gender equity in programming and to describe to you what that looks like in terms of steps within the Secretariat, our process for designing grant applications, as well as the types of interventions that we're now seeing in countries. I'm sure many of you have already seen the new Gavi 5.0 strategy with a vision to leave no one behind with immunization. What I'd like to bring to your attention here is that gender is central to the vision. It is elevated as a principle, and it's also core to our goal on equity in immunization. We have a policy which has a goal to identify and overcome gender-related barriers to reach zero dose and under-immunized children, individuals, and communities. And it encompasses three main areas of work. The first is to identify and address the underlying gender-related barriers faced specifically by caregivers, health workers, and adolescents. It encourages and advocates for women and girls' full and equal participation in decision-making related to health programming and well-being, and in the specific pockets where they exist, to overcome differences in immunization coverage between girls and boys. Within the Secretariat, we've taken a number of steps to mainstream across our practices. The first is to galvanize our support and to enhance our capacity and understanding and skills. And we've done this through providing informal learning sessions, webinars, and sharing stories on gender and immunization. We've also developed formal training courses. So one we're developing with George Washington University through the Gender Pro program. And we've developed a specific immunization track for that course. And there'll be a short course, which is about a month long, and a long course. And these are intended for Gavi Secretariat and Alliance partners. We've also partnered with Bull City Learning to increase the number of videos that they have available for health workers on gender and immunization, as well as we've developed 2 courses with them, which will be online through the Immunization Academy, one for health workers and one for supervisors, again, addressing the gender-related barriers in immunization programming. The second step we've taken is to increase our coordination across the Alliance to ensure that we have more complementary programs and to build on each other's programming guidance and lessons learned. Our third approach is refining our approach and guidance. And we've done this by developing guidance to have an inclusive and diverse full portfolio planning process. So that's the process that Gavi uses to develop grant applications. And we're also promoting the use of participatory approaches such as human-centered design, which we've seen as a really effective way to bring out communities' identification of gender-related barriers. Our zero-dose strategy integrates gender-specific considerations, and we've developed program funding guidance, which includes very practical gender-specific interventions at all the different stages of an immunization program. We've set expectations for gender integration in our applications, monitoring, and reporting systems. So we have guiding questions throughout our grant application. That means from our situation analysis to the theory of change, to the work plan, to the M&L plan, as well as the budget. And this is the first time that we've asked countries to mark to what degree activities will address gender-related barriers, and they'll be marking that in the budget. We also have a new fund available to support testing and sharing of information around gender responsive and transformative approaches. And this is a way to build up evidence and understanding around these areas. So that's what's happening within the Secretariat. At the country level, we're supporting countries to use the IRMA framework. That's the Identify, Reach, Measure, and Monitor and Advocate framework. So the first step there is to help countries identify where, who, and why they're zero-dose children. And we've integrated gender in there by asking the question, what are the barriers faced by caregivers, health workers, and adolescents? On the reach side, this is about tailoring strategies that will be sustainable, and they'll address both the supply and demand side within the immunization program. And there we've also supported countries to identify the gender-related barriers and ensure that they're addressed through specific interventions. The next step is to measure and monitor. And this we're moving forward by ensuring that the monitoring is happening on a much more rapid pace than has been done before. And we're encouraging sex and gender-related data to be measured and monitored. And then, of course, on the advocacy side, that's the step to use evidence to make a case for political attention and resources. And for gender, we want to ensure there that we're building the evidence and we're strengthening the political will towards addressing gender barriers. So if we take that framework and we look at zero-dose communities, we often see high zero-dose populations in urban slums, in remote communities, and populations in conflict settings. And if we do a gender analysis, we can find different types of gender dimensions in those different communities. And again, this is an important step that we're doing with countries to ensure that they have identified what the barriers are. Another really effective way that we've helped identify what the barriers are is using something called the behavior and social driver framework. And this really asks the question, what drives uptake? And you'll see on the left-hand side, we ask people what they think and feel around vaccine benefits and safety, and also what the social processes are in terms of their decisions around going for vaccinations. And it also looks at motivation, so families' intention to get the vaccines for their children. And although this is out of the power of caregivers, we also look at the practical issues that they face to access the vaccines. So we see these as core steps that an individual will take and have to go through in order to get their children vaccinated. And if we look at the social processes, there's some key questions that we've learned have given us really important information to help design effective immunization programming. So for example, using this framework, there's survey questions which ask about decision autonomy. And it asks, in your family, who has the final say about whether a child will be vaccinated? Or there's a question about travel autonomy. So if it was time, would you need permission to take your child to the clinic? And these are questions which we have not been asking in the past and which really give us information that is key to designing a program which will effectively reach the communities, and particularly the communities that we continue to miss. So moving forward on the question around who has the final say about vaccinating your child, I'm just sharing with you a graph that compares the responses over a number of countries. And you'll see here, the top country here is Uganda. And you'll see the yellow means that both of the parents have final say. The green means the mother has final say. The purple is the father, red is the grandmother, and blue is an other caregiver. Now, in the past, we've just assumed that a mother would have the final say, as she's the one who is normally in charge of children. So asking these questions gives us really relevant information for how we would change who we reach out to, how we message about it, and it helps questions our assumptions. So that's just one step that we're taking or working with countries to use this framework to help get more detailed information for more effective programming. And there's a number of other interventions, based on that information, we've developed other gender responsive interventions which are addressing different barriers. So again, along the lines of who has the final decision, we're looking at different approaches that promote the involvement of fathers in immunization. So we're working in Zambia, Mozambique, Togo, Afghanistan to promote involvement of fathers. In India, we are integrating services and as well having a duo health ambassador. So both men and women health ambassadors work with parents, so both mothers and fathers, to improve fathers' involvement in immunization services. In Somalia, to overcome the barrier of few women being involved in vaccination and many caregivers not wanting to access vaccination services by men, there's a promotion of female vaccinators in Somalia, as well as Afghanistan. And I think there's one barrier that many people around the world face, and that's just the clinic hours being not open at the time that is accommodates working parents. So in Bangladesh, they're extending the clinic hours, and we're watching that to see how well that will actually address some of the barriers that working parents, particularly women, face when they're trying to access the services. So these are just some examples of areas that we're trying through Gavi programming, and we're measuring the results of those. But I'd be happy to answer any questions during the Q&A about other steps that Gavi is taking to promote gender equity across its immunization programming. Thank you.